Now we're going to do a series of short tutorials on how to manage the shocked patient. The first type of shock that I'm going to talk about is hypovolemic shock, where the patient has lost volume. It's usually blood, but it can be extracellular fluid. An introduction to critical care. With me, your host, Pat Nelligan. We're discussing cardiovascular assessment. And this tutorial is on the blood pressure, specifically looking at hypovolemic shock. Previously, I discussed hypotension being caused by a loss of heart rate, stroke volume, or peripheral resistance, and failure of the other components to compensate. Shock is inadequate tissue blood flow or cardiac output to maintain homeostasis, and patients can be hypotensive without being shocked and shocked without being hypotensive. In this particular tutorial, we're going to focus in on hypovolemic shock, the patient's response to hypovolemia, and how to monitor it. Let's start with the scenario. Jack is a 36-year-old male unrestrained driver. He is involved in a motor vehicle crash against another car. It's a T-bone collision. Jack is ejected from the vehicle and found along the roadside. Now you arrive at the scene. There's blood gushing from Jack's leg. Should you put a tourniquet, such as a belt or a tie or a piece of rope, around Jack's leg? 10% of all blood volume is in that leg. So absolutely, yes, you should put a tourniquet on his leg. It will save his life by arresting life-threatening bleeding. It will restore the blood pressure and reduce blood loss with a modest risk of complications. Jack arrives in the emergency room. His temperature is 34.9 degrees Celsius. Hypothermia kills. There is a classic triangle of death that's been known for decades in trauma situations. These include coagulopathy, acidosis, and hypothermia. There is a clear correlation between the degree of hypothermia and adverse outcomes in acute trauma situations like Jack's. Why do patients become hypothermic? Well, part of it is the ebb phase of the stress response. By slowing everything down and cooling everything down, there was reduced oxygen consumption, reduced metabolic activity, reduced heat production, and reduced basal metabolic rate to keep the patient alive while they either heal or somebody comes to help them. The second thing is environmental. Often the patients are found in the field. It's very cold outside. They can't shiver. They're exposed. And then they come into the hospital and all of their clothing is removed as part of the various surveys that are done as part of a TLS. And so you need to start thinking about the temperature, because hypothermia is a bad thing. It's associated with coagulopathies, cardiac arrhythmias, reduced renal and hepatic function. Most importantly, though, impaired immune function, so the patients at elevated risk of developing sepsis, and also the wounds that they have are less likely to heal properly. So you got to keep your patient warm by turning up the room temperature, minimizing skin exposure, put on a heated air blanket like a bear hugger. If you're giving the patient gas, make sure it's heated, such as high flow. Intravenous fluids should be heated, blood products should be heated, surgical irrigation fluids should be heated. Now, Jack has an open fracture and he goes urgently to the operating room. There are multiple long bone fractures. He has a fractured pelvis. He has lung contusions. And on his labs, he has a hemoglobin of 12.6 grams per deciliter, a base deficit of -12, and a lactate of 12 millimoles per liter. The observations reveal a heart rate of 120, a respiratory rate of 40, and a non-invasive blood pressure reading of 80/40. Pay attention to this normal-looking hemoglobin. Immediately after induction of anesthesia, Jack's blood pressure falls to 40/20. Nobody believes this initially. Then they do, and he receives a bolus of phenylephrine, then a phenylephrine infusion, then norepinephrine. At the end of the case, he has passed no urine, his blood pressure is 100/70, and he's on 20 mics per minute of norepinephrine. His legs are mottled. In my view, This care that this patient received represents catastrophic incompetence. And the main reason I make this point, and this is a point you must understand, and I'm going to re-emphasize this several times over the next few minutes, is because hemoglobin is not a reliable indicator of circulating volume. To understand this, we need to understand circulatory compartments. Now, this bottle or these cartons represent a litre, and this square cartony thing is 1 litre of blood. For most people, their total blood volume is about 5 litres. Of that, about 1 litre is in the splanchnic circulation, and about 850 mils are in the heart and lungs. 300 in the heart, 550 mils in the pulmonary vessels. The brain has about 120 mils of blood volume. So when we put all of this together, you can see that the heart and lungs and the arteries contain about just over 1.5 litres. So all of those arteries are 1 litre, and the heart and the lungs is not just a little bit less than 1 litre. So everything else that's not artery must be vein, and venous blood is about 3.2 litres. Where is all this blood? 30% is in the abdomen and pelvis, mostly in what we call the splanchnic circulation. 25% is in the chest. The arms have about 10% and the legs 10% each, so that's 20%. The head and neck, the brain, the scalp, the neck, about 15%. So 2/3 of blood volume is in the systemic circulation, 1/3 is in the splanchnic circulation, and 2/3 of all blood in the body is in veins. 2/3 of this is in the systemic circulation and 1/3 in the splanchnic circulation. So 75% of systemic blood is in veins, most of which are in the abdomen and limbs. The way you need to think about the circulation is that there are 2 major compartments. There is a fast compartment, which is the main circuit plus the extremities, where blood goes around very, very, very quickly in exchanges. You need to send blood to the brain and to the muscles to keep moving and thinking. We have a secondary compartment, which is the slow compartment, that is the splanchnic circulation. So blood goes into the splanchnic circulation, it runs around the bowel, goes to the liver, the spleen and the kidneys, and then goes back into the systemic circulation. Blood flow to the liver is relatively fast, blood flow to the bowel is very slow. So overall this compartment is relatively slow. I want to now try and elaborate on 2 terms that I have used in the preceding tutorials and ones that I will use again in the future, and they are the stressed and unstressed blood volumes. The unstressed blood volume is the amount of fluid or blood that fills up the circulatory system without increasing the transmural pressure. These are essentially floppy veins in the slow circuit of the circulation. Blood flows slowly through them, and that blood does not pressurize the wall of the vessel. At rest, much of the circulating volume is in this state. The stressed blood volume is the volume that stretches the vessel walls, and it makes up about 25% of total blood volume. If the blood volume is 5 litres, then only 1.25 litres stretches the vessel walls and stimulates elastic recoil. But that volume is critical to ensuring that venous return functions normally. When large amounts of catecholamines are generated either endogenously or administered exogenously, and that usually happens because the patient is either vasoplegic or the patient is hypovolemic. Once those catecholamines hit alpha receptors, there is widespread vaso and venoconstriction, with the effect that the unstressed blood volume becomes stressed. This increases venous pressure and improves venous return. It is one of the major homeostatic responses to blood loss. In this model, the cylinder represents the blood volume divided in 2. On the bottom is the unstressed blood volume. That is connected to the heart by a tube. for example, the inferior vena cava. The tube is located near the top of the unstressed blood volume. The unstressed blood volume therefore contributes very little to the flow of blood from the cylinder to the tube to the heart. The force that propels the blood into the tube is the volume above the unstressed blood volume, the stressed blood volume that provides a hydrostatic pressure into the tube. That is the driving pressure for venous return, and it results in providing adequate end diastolic volume to the heart to eject a normal stroke volume. If a significant quantity of blood is lost, there is a reduction in the stressed blood volume. The hydrostatic pressure for venous return is lost, and this results in a reduction in the end diastolic volume, a reduction in the stroke volume and cardiac output, and ultimately hypovolemic shock. The body responds to this by generating large quantities of endogenous catecholamines that cause venoconstriction. The effect is to recruit and re-stress the blood volume and restore the driving venous pressure. The stroke volume is somewhat restored. Rarely does it reach baseline levels, and that's why it's worth measuring stroke volume. And the body auto-resuscitates itself with blood from the venous reservoir. With these concepts in mind, let us now explore how catecholamines stress the macrocirculation. With the massive release of endogenous catecholamines, all aspects of the macrocirculation are impacted, so there is vasoconstriction of all vascular beds, arterial and venous. Blood pressure is maintained because of high peripheral vascular resistance. There are various changes to the cardiovascular system. There is a reduction in cardiac output because of a reduction in venous return that leads to a reduction in stroke volume. There is decreased blood flow to the extremities that may result in mottling. And there is reduced splanchnic overall blood flow, pooling of blood in the splanchnic circulation, poor perfusion of the bowel and the liver, and an increase in the lactate as a consequence of reduced hepatic consumption of lactate, and also increased bowel and muscle production of lactate. Now, looking at the measurements that we make in the macrocirculation, we have a mean arterial pressure of 65, a CVP of 3 centimeters of water, and a hemoglobin of 15 grams per deciliter, or a hematocrit of 45%. In this normal situation, the circulating volume is 5 liters. And the patient becomes injured and they bleed. And there is a 2 liter blood loss, and there is intense vasoconstriction. Now we have a 3000 ml, 3 liter circulating volume. But the blood within that circulation has not changed. And so the mean arterial pressure due to intense vasoconstriction may be the same. The CVP may be the same. The hemoglobin may be the same. And this is where things get very misleading. And that's why our patient in the operating room got norepinephrine, not blood products, for resuscitation. The way I've tried to explain over the years why this is if you look at bottles of, for example, Coca-Cola. A 2 liter bottle of Coca-Cola has the same concentration of Coke as a 750 ml bottle or a 330 ml can. It's the same stuff. It doesn't change. What is different is the volume in which that cola is being delivered. And when your vascular system has intense vasoconstriction associated with hypovolemia, that hemoglobin will stay, at least initially, relatively normal. Occasionally it goes up, occasionally it drops. An early cause for the hemoglobin to drop just a little bit occurs due to the impact of vasopressors, catecholamines on the microcirculation. Epinephrine, norepinephrine activate both pre- and post-capillary sphincters, shutting down microcirculatory blood flow. And the blood that does travel through the microcirculation travels at very high velocity, and that has the impact of actually sucking fluid back into the venous side of the circulation. This is known as transcapillary refill. Normally, fluid in the interstitium is returned to the cardiovascular system by lymphatics. And so the hemoglobin only starts to fall when lost blood is replaced by water, and usually that's intravenous fluid. And our patient Jack has lost 2,000 mils of whole blood. So is Jack in hypovolemic shock? Well, he'll be cold and clammy and hyperadrenergic. You'd expect oliguria to take place. So in any stress situation where antidiuretic hormone is produced, urinary output falls even if the volume of blood in circulation is normal. Central venous pressure, which is an absolutely useless monitor of circulating volume, and mean arterial pressure may look normal, and both of these are quite unhelpful. And hemoglobin is particularly useless. In ACLS, there is an approach to looking at volume loss, and the system that they use is the tennis match approach, which is 15, 30, 40, game over. When there is 15% blood loss, they call this class 1 hemorrhage. That's up to 750 mils. In general, the heart rate is less than 100 and the blood pressure is normal. The pulse pressure may be normal or increased. The patient will not typically be tachypnic. They'll still be making urine and they'll be quite anxious. So it's very hard to really evaluate this patient for significant blood loss. With 30% blood loss, we start to see some changes. We call this a class 2 hemorrhage. So that's 750 to 1500 mils. The heart rate absolutely goes up above 100. The blood pressure will stay normal due to intense vasoconstriction, all the way up to 30%. The pulse pressure, though, will be decreased because that systolic pressure is now soft. The patient will be developing an acidosis, so they'll be becoming tachypnic. The urinary output will typically fall, and the patient will become quite anxious and diaphoretic because of all the epinephrine, the adrenaline circulating. Now we're at 40%. In this situation, the patient, like Jack, has lost 1,500 to 2,000 mils. The heart rate will be very fast, 120 to 140. The blood pressure will be decreased because you have used all of your unstressed blood volume. It's all gone. It's all been compressed into the circulation. There's nothing left. And because of that, the venous return is inadequate to generate a full stroke volume, and the intense vasoconstriction just isn't enough to keep that blood pressure up. The pulse pressure will be reduced. The patient will be really tachypnic from all the acidosis and also the work of trying to transport all of that oxygen around the body. Urinary output will be negligible, and the patient will become confused and anxious because of poor cerebral perfusion and intense cerebral vasoconstriction. And now we're at the end game. Class 4 hemorrhage, more than 40% blood volume lost. Severe tachycardia in excess of 140. Blood pressure very low. Pulse pressure very low. Very tachypnic. No urine being produced, and the patient will often be comatose. You really don't want to see this, and if you do see it, you need to aggressively resuscitate the patient with, if they're losing blood products. Now, that heart rate response is not always there. Generally, if the blood pressure falls, the heart rate goes up. But some people cannot generate a heart rate response, particularly elderly patients who have autonomic dysfunction or have pacemakers or are being treated with beta blockers. Occasionally, some patients seem to just not be able to generate a tachycardia. We're not sure why. In some cases, it's because they have an intra-abdominal hemorrhage and they're stretching their peritoneum, and the vagal response overwhelms the sympathetic response. But honestly, we don't know. What we do know that is hypovolemic shock, lactate production increases and clearance decreases. So when you do a blood gas, you will see an acute metabolic acidosis and profound hypovolemia. There will be a drop in the pH, a drop in the PaCO2, a drop in the bicarbonate, and a lactate and a base deficit that more or less equal each other. So if the lactate is 12, the base deficit is usually 12, and that represents the fall in the bicarbonate from what is normal for that patient. There's your lactate. And the reason why lactate is high is because the body produces a load of lactate that increases when the patient has a lot of circulating epinephrine. You need a lot of glucose to feed all those red cells, and those red cells produce an awful lot of lactate, as do the muscles, as does the stress response. So all this epinephrine increases the production of lactate from the body. It increases glycogenolysis, it increases gluconeogenesis. It feeds the whole system that generates lactate. But overall, we have this reduced splanchnic and extremity blood flow. So simultaneously, tissues that normally generate a lot of carbon dioxide from aerobic metabolism are now generating lactate. So there's lactate being produced from various different tissues, from the arms and the legs, the splanchnic circulation, and particularly the red cells. And simultaneously, the poor splanchnic blood flow results in poor hepatic function. The liver isn't seeing the lactate to turn that lactate back into glucose via the Cori cycle and gluconeogenesis, and so the lactate is not being cleared. So high lactate that is rising is a really bad sign in a hypovolemic state, and that's why lactic acidosis is considered a really good marker of severity of illness. If the lactate is more than 5 millimoles per liter and rising, this is very bad. The other number that we've traditionally looked at in hypovolemic shock is the mixed venous oxygen saturation, and that is an excellent indicator of tissue perfusion. If you measure the arterial oxygen saturation, it's usually 99 or 100%. If you measure the mixed venous oxygen saturation in the pulmonary artery, because that's where all the superior vena cava blood and the inferior vena cava blood mix together, so you get the total mixed venous oxygen saturation, that's about 75%. Normally, though, we don't put in pulmonary artery catheters in patients who are bleeding, and so the place that we measure mixed venous oxygen saturation is really from the SVC distribution, and because the head removes more oxygen from circulating blood than, for example, the legs in the systemic circulation, the SVO2 in the SVC distribution from a central line is usually around 70%. When the blood volume is 5,000 mils and the hemoglobin is 15 grams, and in normal circumstances, we take off about 250 mils of oxygen per minute. The venous oxygen content is about 5 mils per 100 mils lower than the arterial oxygen content. And because the oxygen delivery per minute is about a liter, the mixed venous oxygen saturation is 75%. When blood volume falls and the hemoglobin is the same, so per 100 mils the arterial oxygen content is exactly the same, and the saturation of arterial blood is exactly the same. But what we're missing here is, of course, the total volume. And in this situation, the cardiac output is much lower. The stroke volume is only 30 mils. There's 100 beats per minute, so only 3,000 mils of blood are being delivered to the system, and the oxygen delivery has fallen from 1,000 mils to 624 mils. But the same amount of oxygen is being extracted from the blood per minute. And because of that, the mixed venous oxygen content has now fallen to 8 mils per 100 mils. So now we have a gap of about 12 mils from the arterial to the venous oxygen content. And as a consequence of that, the mixed venous oxygen saturation is 45%. Low mixed venous oxygen saturation means far more oxygen is being extracted per unit blood. So in hypovolemic shock, we see this situation where the mixed venous oxygen saturation drops as the lactate rises. A mixed venous oxygen saturation of lower than 50% is very bad. How do we figure out if the patient is fluid responsive? So if we have that patient who went to the operating room who was given norepinephrine rather than blood, what would we do differently to figure out if the patient was hypovolemic? And the system that I believe is the best is known as pulse pressure variability or stroke volume variability. I discussed pulse pressure variability in the tutorial on the pulse. Just to remind you, during the respiratory cycle, when we run the arterial line and the end-tidal CO2 at the same speed, we see a bit of variability in the pulse pressure. On inspiration, when a patient is on a ventilator, the pulse pressure goes up and then it falls during expiration. The degree of change in that pulse pressure is very important. Anything over 13% is usually a sign of fluid responsiveness. This patient has a blood pressure of 106/61 with a MAP of 72. I've compressed the arterial waveform to the same speed as the end tidal at 6.25 millimeters per second. So if you saw the blood pressure, you'd be quite happy that this patient is perfusing well. But the arc line waveform tells another story. There's a real roller coaster effect going on there. And I've activated pulse pressure variability. And if you look carefully here inside this green ring, you'll see the PPV is 23%. That is extremely high. As a rule of thumb, a 13% fall in the pulse pressure during expiration is a sensitive indicator of fluid responsiveness. If the PPV is over 25%, that is really bad. So in terms of determining the need for resuscitation, you have those objective measures: pulse pressure variability, stroke volume variability. I'll talk about those in a separate tutorial, and pulse contour analysis, available on some of the hemodynamic monitors that we have, like the FlowTrack Vigileo or the MoseCare. And then there are the pragmatic measures: the presence of a lactic acidosis that is not correcting, and low mixed venous oxygen content. In general, in terms of the trauma patient, what you need to do is resuscitate the patient, control the source of bleeding, and avoid fluid overload. The treatment for blood loss is blood products, not crystalloid. In hypovolemia, crystalloids will rapidly restore the unstressed volume, so it's not unreasonable to give the patient a slow infusion of crystalloid to refill the venous side of the circulation while you're waiting for blood products. A litre, maybe 2 litres is perfectly fine. But as those vessels become stressed, fluid extravasates into the interstitial space, and this is enhanced by squeezing the bag. By squeezing the bag, you're essentially shoving all of that fluid into the interstitium. You're not resuscitating the patient, you're effectively drowning them, and you're fracking the interstitium. Fluid extravasation increases exponentially as the volume of crystalloid that is administered increases. Now, the major problem with crystalloids is that although they may restore circulating volume, they don't deliver oxygen. So even though that cardiac output might increase to 5 litres, the proportion of oxygen extracted per unit hemoglobin is the same. So the mixed venous oxygen is not going to improve dramatically. There's also a problem with a dilutional coagulopathy and clot disruption, and of course the issue of edema, because edema occurs when fluid enters the interstitial space. So patients will get pulmonary edema, pleural effusions, bowel edema, and that might result in abdominal compartment syndrome. The other thing is that patients lose whole blood. We can't give patients back whole blood. We have all kinds of different blood products. We have red cells, we have platelets, we have plasma. And if you're doing a big resuscitation on a patient who is bleeding, they need to be given red cells, plasma, platelets, and fibrinogen. If you just give red cells alone, the patient will be inadequately resuscitated and coagulopathic. And remember that coagulopathy is part of that triad of death. Finally, hypotension that does not respond to volume when the source is controlled may be caused by a compartment syndrome. Compartment syndromes exist when expansion of one component of a compartment causes damage to all other components, or a new component enters the compartment, and this might be life-threatening. Cardiac tamponade is an example of a compartment syndrome. If the heart is punctured in any way, if blood extravasates from the heart into the pericardium, that blood clot can prevent the heart from filling and tamponade it, preventing the heart from pumping effectively, and it needs to be drained. With rib fractures in trauma, a patient may well have a tension pneumothorax. This can also happen from a poorly placed central line. That compresses the heart and great vessels, reduces venous return, reduces cardiac output, and results in hypotension. Traumatic brain injury is another example of a compartment syndrome, but in this setting it's also important because of what I call brain in blood syndrome. The damage to the brain can release a whole bunch of vasodilator metabolites that are released into the vascular tree. It causes vasoplegia, the blood pressure drops, and that can be misunderstood as bleeding, leading to, for example, a patient having a laparotomy. Normally, the intra-abdominal pressure is lower than 12 millimeters of mercury. If it's greater than 12, then the patient has intra-abdominal hypertension. Abdominal compartment syndrome is a very specific disorder of intra-abdominal hypertension. Usually, but not always, there is a sustained increase in the intra-abdominal pressure more than 25 millimeters of mercury, and that leads to organ dysfunction, one of which is oliguria, presumably caused by ureteric compression, low chest wall compliance, meaning that it's really hard to ventilate the patient, and the patient may have difficulty breathing because the diaphragm is being pushed northwards, and hypotension, presumably caused by IVC compression. And abdominal compartment syndrome commonly follows a massive crystalloid resuscitation. We used to see this quite a lot 20 years ago when trauma surgeons were obsessed with giving large volumes of crystalloid, particularly to try and wash out lactate that they considered to be a harbinger of bad outcomes in trauma. However, things have changed and much less crystalloid is given these days. We see fewer cases of this. If you want to measure intra-abdominal pressure, this is done by placing a transducer on the urinary catheter and measuring intra-abdominal pressure via the bladder. Let's review this tutorial. In this tutorial, we looked at hypovolemic shock specifically associated with major blood loss. Hypothermia, acidosis, and coagulopathy in trauma situations is an indicator of high risk for death. The hemoglobin is an unreliable measurement of circulating volume status. The lactate and the mixed venous oxygen saturation are good pointers to the degree of blood loss and the status of the circulation. Lactate, by the way, is not a particularly good endpoint of resuscitation. If you're going to look for an endpoint of resuscitation, the easiest one to use is pulse pressure variability. If you have it, you can also use stroke volume analysis or stroke volume variability from pulse contour analysis. Resuscitate bleeding patients with blood products, not vasopressors, and if the patient is fluid resuscitated and they're still hypotensive, consider compartment syndromes. Next time, I'm going to discuss septic shock, the mechanisms of hypotension in sepsis, fluid resuscitation in sepsis, and vasopressor therapy in sepsis. I'll see you then, and I guarantee you'll learn something. I hope you're enjoying these tutorials. If you are, please subscribe on YouTube, leave me some likes and some comments, introduce me to some of your colleagues or friends, and follow my blog at ccmtutorials.org.